Hi, it's Dr. Centeno, and thanks for joining me today. Running just slightly late here. Today we're going to talk about an interesting topic, and that is a problem I see that's super prevalent. I would say probably 90% of the patients I see that come into my clinical practice who are being worked up for craniocervical instability have headaches that are coming from their neck, but they only ever saw a neurologist to try to diagnose the cause of the headaches. And many times they just are on the wrong medical track. They probably would have gotten to me much sooner had they actually gotten on the right medical track much earlier. And so this is a big problem. It's a big problem that I think we need patients to advocate for. We need patients that understand it so that if you're on social media and you see someone that's on the wrong track, you can at least get them to the right track. So we're going to go into that. As usual, I will certainly answer questions about this topic or any other topic you have. I know I've got lots of questions to catch up on. I did 3 straight interviews of providers, patients, and it's always a little harder for me to get to questions during those types of episodes, but today I should be able to get to quite a few. So let me go ahead and share my screen here today. Okay, so we'll get started again. Today's topic is on the concept that patients frequently get on the wrong track to diagnose their headache pain. And I'm going to talk about what I mean by that, but it's a big issue. About 90% of the patients that I see are on the wrong track. And had they gotten on the right track early, they would have figured out very early on that their upper neck was causing their headaches. And then when that didn't resolve their issues, they would have then found us much, much sooner. So headaches are common in patients with neck pain, and especially traumatic neck pain. And they often originate from the upper neck. In fact, the upper neck and the head develop together embryologically. So your body can't really tell the difference between pain that's coming from your upper neck and pain that's coming from your head, because to your brain, they're the same. And what you may not know is that your ability to get to the real cause of your headache and get that accurately diagnosed may depend solely on the type of doctor that you decided to see or that you were referred to. And what I mean by that is frequently when you go see your family doctor, you've got a headache, you get a referral to neurology for the headache. And what most people don't understand and what most patients don't understand is there are 2 very different tracks here in headache diagnosis. And most people with cervicogenic headaches or headaches coming from their upper neck get on the wrong track. And that wrong track really causes them a lot of problems because they're not getting answers to what's wrong. And hence they're not getting to treatments that even can provide temporary relief, let alone permanent relief. So 2 tracks that I'm talking about are neurology, which is the common track. And if you get on the neurology track, what you tend to get is headaches are only caused by either a migraine, which is a vascular neurologic event, and occipital neuralgia, which is irritated nerves back here. So that approach, 90 to 95% of the time, is medications, usually traditional migraine medications, or maybe some of the brand new migraine medications, or sort of a blind occipital block back here. And so this is a big problem, right? Probably 90% of the patients I see are on this neurology track, and they never get to the other track, which is the interventional spine track. And here interventional spine trained physicians, and there are many in the United States, recognize that headaches are very frequently caused by upper neck structures. Obviously, they can also be caused by migraines. But if someone's seen a neurologist and they're not getting, home run relief from migraine medications, then they need to get to an interventional spine physician. And in that category, you can get image-guided facet injections, medial branch blocks, spinal nerve blocks, and other treatments that can be used to manage headaches. Lots of different kinds of treatments on that side, and it's all about identifying where the headache's coming from. So had they gotten on that interventional spine track or had gone from the neurology track to the interventional spine track, they would quickly see, many of my CCI patients, that their headaches were coming from their upper neck. Now, maybe they don't really someone don't get fully there because many of those interventional spine doctors don't like injecting above the C2-3 level. But at least those doctors can say, you know what, I think this is still coming from your neck. Maybe it's coming from higher than I'm injecting. I did C2-3, that didn't help. Maybe it's coming from 0-1 or 1-2. I'm not comfortable doing those injections, but maybe someone out there is. So as you can see, these 90% of patients that get stuck on the neurology track that never get to the interventional spine track would figure out pretty early that they have some pretty substantial issues in their upper neck that need to be further investigated, which would make sure that they get into our clinic to treat their CCI much, much sooner. So again, the neurology track that people get stuck on, migraine medications, right? Migraine medications generally aren't a home run in these CCI patients. Some of the newer migraine medications, as they work differently, and some of those are biologic anti-inflammatories, may help them. But when it comes to traditional migraine medications where someone can get an aura, like they get a visual change and they go take a migraine medication and boom, it just wipes it all out, that generally doesn't happen for CCI patients or patients with cervicogenic headaches. So they get stuck on this neurology track. Maybe it's not working at all. Maybe it's working a little bit, but they're just not getting answers here. And what should be happening is they should get referred from here directly over to the interventional spine track, but this just doesn't happen in my experience. Only about 10% of the time, or 1 in 10 of the headache patients that we're seeing who are trying to see if they've got CCI or craniocervical instability, have had a proper interventional spine workup. They just don't get on this track. And there are dozens of different image-guided diagnostic blocks that can be done to identify the source of the headache in the upper cervical spine. So what are those sources? Well, diagnostic blocks are if you numb something up and the pain goes away, in this case, the headache pain, you know the source. So these are just some of the upper neck sources. So the upper cervical facet joints, 0-1 facet joint, 1-2 facet joint, 2-3 facet joint, the occipital nerves, greater and lesser third occipital nerves, the C2 dorsal ganglia, the C2-3 disc, and other structures I'm not listing here. These are just sort of the most common ones that we tend to see, the top two being the absolute most common. Probably about 90% of all patients with headaches coming from their neck fall into those two upper categories there. Now, something that you've got to consider, and I talked about this a little bit in the beginning, and that is 0-1 and 1-2 facet injections require advanced skills and training. No other clinic on earth outside of our Colorado clinic performs these procedures in what I would consider a high enough volume to be expert in this. And a high enough volume is, for example, I probably do, I'm going to say 500 to 800 0-1 injections a year right now. And you compare that to a clinic that's probably only done 30 of these in their entire career, let alone in a year. And if we go to clinics that have done more than 100 of these in their entire career, that's only about 100 US clinics. The biggest issue with these levels is that they are higher risk. And I've never had a problem with them. I've done thousands. And our clinic has never had a problem with them because, we've got all the proper equipment to do this. We've got a lot of experience of how to handle the anatomic variations, but they are higher risk. And that's why a lot of clinics won't touch them with a 10-foot pole. And that's why some clinics will do them, but don't really have the experience level necessary or similar to the other levels in the neck that they would inject, where they've done thousands of those procedures. So in conclusion, making sure you're in the right track to diagnose cervicogenic headache is really the key here. And we see lots and lots of patients get on the neurology track, and they really just kind of get stuck there. I just want to make sure we're not having problems here. But they get stuck on the neurology track and really go nowhere. And then it's time to switch tracks. And switching tracks would be on to that interventional spine track. And finding out if your neck is causing your headaches is really the standard of care. So very, very important that you get on the right track early. So let's go to questions here. Ryan just got treated with first PICL last week. Let me move this over here. Moderate sleep apnea is something that can improve once the structure of the neck improves. Yeah, Ryan, so we certainly see CCI patients that have sleep apnea, and it's our belief that that's either due to upper cervical instability or jaw instability. We also have CCI that are carrying substantial extra weight, and it's probably more due to that. So, I would say if you're carrying any extra weight, drop the weight. We're in an interesting time now with all of these peptide-based obesity, diabetes drugs, Ozempic, and similar drugs. So there's never been an easier time to drop 30 or 40 or 50 pounds. If that's not the issue, then absolutely it could be your neck. And we certainly have seen patients with sleep apnea that gets better once we improve that structure. AT, in general, the reason of feeling more unstable after PT or traction is because of joint or nerve irritation causing muscles to go offline temporarily. Correct. Unlikely that this is harmful. Usually, but I'd probably need to know a little bit more. I think, AT, that we're in communication via email, so probably better for something over an email exchange there, so I can learn a little bit more there. AT, gentle chin tucks while laying under a dinner roll. If able to tolerate for longest capitis activation, I'm finding this better to tolerate the biofeedback cup, DNF. Sure, yeah, that sounds like a reasonable trade-off to me. Just so that people understand what it is you're talking about there, AT, because I think it's an important topic. AT is talking about the deep neck flexors in here, the longus colli and capitis. And those are muscles that can go offline in craniocervical instability or patients with cervicogenic headaches. So he's talking about working on trying to get them back online, which is that deep neck flexor DNF stuff he's talking about. And there's a biofeedback cuff that almost looks like a blood pressure cuff that you put back here, and then you try to flatten out your neck, which is what those muscles do to try to train those. Liza, the worst part is when you have neurologic and neck-related headaches, confusing things even more. Yeah, so Liza, one of the other causes of headache here can certainly be intracranial hypertension, but I will tell you that probably 75% of the patients that we see who have been diagnosed with intracranial hypertension-related headaches or internal jugular vein compression-related headaches don't really have those. They have more common headaches that are coming from the upper neck structures. So I see that being way overdiagnosed right now. And obviously, if I can block your 0-1 facet joint with an anesthetic, and in 5 minutes your headache goes away, goes from a 9 to a 2, you don't have intracranial hypertension-related headaches. So I think that's being way overdiagnosed. Most of our patients have headaches that are actually coming from their high upper neck structures. Let me get rid of that there. Kimmy, I have constant Rice Krispie sounds in my ears. The past 24 hours, I've had muffled hearing and more balance problems, dizziness. My atlas is in place, was checked yesterday. Just wondering if you have any videos or blogs about eustachian tube dysfunction or can shed some light on your issues with CCI, AAI. Yeah, CCI and AAI can certainly impact the eustachian tubes. As far as solutions go, I've seen it be related quite a bit to irritation of the sternocleidomastoid muscles here. So I think my first thing to check would be whether or not those are tight, and you might try some gentle massage or myofascial release in that sternocleidomastoid. Those are the muscles that come this way, to see if that impacts that issue. Bo, how long after PICL can I use an inversion table? Yeah, Bo, we're definitely going to want to make sure that you're stable before you do that, or at least that you've never had any problem with it in the past. So for example, let's say you've used an inversion table for years. It tends to help you and it tends to reduce your symptoms. You could really go back to using it right after the procedure. Now, if you're in another category, right? If you're in the category, well, I'd like to try it for the first time. I don't know how I'm going to respond to it. Then I'm going to require that we stabilize things first before you do it. And that's because if there's any vertical instability, it could make your symptoms worse. Kimmy, upright MRI shows IJV and cranial nerve compression, doesn't mention the vertebral arteries. Is there a way to check just these arteries where vertebral artery compression be obvious in symptoms? Yeah, Kimmy, upright MRI isn't capable of showing IJV and cranial nerve compression, and that's because that whole area on any MRI, other than a specialized one, is going to be what's called a flow void. So we're not going to see much detail there at all. Now, I can certainly look at those and say, well, this could represent possibly some IJV compression here. But the only way to really tell if that's present in a standard of care way is to do a CT venogram. And a CT venogram is going to allow us to see if there's flow through that area. There's just no reason to do it because there's a high false positive rate. So I just had this conversation with a physician, mother of a patient just recently. She asked about the same issue. And I said, listen, IJV compression is probably happening in a lot of CCI patients. The goal is to treat the CCI. Getting a CT venogram is going to be 80 chest x-rays, 80 worth of x-ray exposure. And then on top of that, there's a high false positive rate. So that means that even if we see IJV compression, it's not uncommon for us to see it in people who are just walking around on the street who have no problems and no headaches at all. So probably not worth doing a CT venogram at this juncture. As far as the vertebral arteries are concerned, vertebral artery issues are rare unless it's related to dissection. And that's something that would be detected on usually a routine MRI. So it's unlikely that there's vertebral artery dissection. As far as intermittent vertebral artery compression, they're designed to be intermittently compressed, so probably not as big an issue there. Liza, yes, my migraine med Nurtec seems to help my CCI headaches, but not full relief. I believe it was inflammatory factors helping. Yeah, that's usually what happens. So these patients that are on the wrong neurology track, usually they'll get to one of the migraine meds that is more anti-inflammatory approach that seems to help, but just helps a bit, rather than the home run relief that actual migraine patients get. Just realize that if you've got a true migraine vascular type headache and you take a migraine medication, it's like someone turned on the lights. So if you're getting that kind of relief, it just means you've been on the wrong treatment track throughout. Collagen isn't one of the supplements recommended for genetics for stem cells or ligament healing. Why is it heavily marketed? It helps ligament healing turn into the public. because there's all sorts of things marketed to the public that we have no idea if they work or they don't work. Collagen certainly makes some common sense, so it would be an easy sell, right? The ligaments are made of collagen, so you should take more of it. And there certainly might be people who don't get enough collagen in their diets, but most of us do. So yeah, we don't have nearly the same amount of randomized controlled trial data on the use of collagen as we do for glucosamine, chondroitin, etc., with regard to pain, joint pain, etc. Why is collagen so heavily marketed with so little data that it actually does anything for ligament or tendon healing, meaning we don't have a single randomized controlled trial that's ever been done on tendon and ligament healing and collagen? Because it's an easy sale and people are gullible and they'll buy it. I mean, that's literally the answer. We don't use it because there's no research showing that it will help that problem. So not really, it might work, it might not work. If someone's a big advocate for it, they should pay for a randomized controlled trial to see if it works. Becky, Dr. Centeno, I repeatedly hear from those of us in CCI should not do any type of chin tuck. My physio has helped me immensely with fascia and muscle work, says that he doesn't know a better way to work the deep neck flexors. He's just lying on your back, first gently pushing suboccipitals down, a gentle and slow chin tuck. Can you weigh in? Yeah, Becky, a lot of that depends on the type of CCI. Remember, there's 8 different types of CCI. Some of those types of CCI aren't going to be affected very much by a chin tuck. Other types of CCI would be more affected. So the first question I would have is exactly what type of the 8 types of CCI do you have? And then I can give you more information on that. So if you have any of the type 1 CCIs, there's type 1, type 2, type 3. There's multiple categories, subcategories within each one of those categories. If you've got any of those, the type 1s, then you're probably going to be more affected by this. I think what your PT may be telling you is that deep neck flexor work, and you don't really necessarily need to do an aggressive chin tuck. All you're trying to do is to put pressure on the cuff, blood pressure cuff, and that is actually flattening out your neck. Now, a little chin tuck will help recruit those deep neck flexors. But listen, I don't think it's going to mess you up. I think if you do a gentle chin tuck and see how you get impacted by it and try to do some gentle deep neck flexor exercises, you can always see if it pushes you over the edge. And if it does, then you don't want to do that. But again, getting an accurate diagnosis of the exact type of CCI that you have would be critical to answer that question. Sonia, sadly, my interventional spine management doctor performed an occipital block and epidural steroid injection, which were effective, but I was still pretty in severe pain in my neck and head. I was told I was catastrophizing and threw a 5-day course of Valium at me to calm me down. Turns out CCI will be going for PSEL in June. Yeah, so I think one of the things to think about here, and this is good that you're bringing this up, is that most physicians get poisoned by the MRI. Maybe that's a bad way to put it, but they go after the bright, shiny, it's called what I call the bright, shiny object syndrome. And that is you look at an MRI, the most common place that you can possibly see issues is in the lower neck, because we all get lower neck degenerative changes as we age. It's like super duper common just with natural aging. So that's where they want to treat. I think as a patient with headaches, if you've got headaches, you want to tell your interventional spine physician, if they didn't get the memo, hey, what I've read online is that headaches come from the upper neck. So you're talking about injecting my lower neck and doing an epidural down here. Can you look at my upper neck? Can you do a hands-on exam? Because when I palpate my upper neck, it seems like I can modify my headache. Again, I can't claim that all interventional pain management doctors are brilliant. I can't claim that they don't have the bright, shiny object syndrome. But I think as patients and advocating for yourself, and that's one of the reasons why we do this every week or almost every week, that's a conversation to have with that doctor. Hey, I've heard this is mostly related to my upper neck. Can we take a look at that? So thank you for bringing that up. Ryan, is the improvement generally progressive after PICL? I know at 3 or 4 month point is the main evaluation point. Up until then, in general, is a progressive improvement, or it's not feeling much of a sudden. So most of our patients fall into one of 3 different recovery trajectories. The first, probably the most common, is there's some sort of honeymoon period, 1 or 2 weeks, where things actually feel pretty darn good. Things are feeling pretty darn good because things are swollen and more stable. So they might have some pain during that period, but they're noticing a pretty good improvement in their symptoms despite pain in that honeymoon period. Then they go in the donut hole, meaning things kind of go back to normal because the inflammation goes away. Then at month 3 or 4, they start to notice improvement. We've also got the second type trajectory where they don't really have a honeymoon period and they just start noticing improvement at 3 or 4 months. And less commonly, usually in our younger patients, we're seeing improvements much more quickly within that 1 month, 2 month, 3 month period. Regenics made advanced by Harry Winston. Is there one distinguishing symptom that differentiates the headaches coming from CCI and other upper cervical issues? Now, remember, the headaches that are generally coming from CCI are almost all upper cervical. So I think if the question is, what's the difference between a headache due to intracranial hypertension? The one thing that would separate most of the intracranial hypertension patients would be tinnitus. Tinnitus is the most common symptom of people with intracranial hypertension. It's usually pulsatile tinnitus. So that would make you think you've got more intracranial hypertension. If you don't have tinnitus and you've got headache, it's far more likely, even though someone might have told you that your headache's due to intracranial hypertension, that your headache's coming from your upper neck structures, and that those doctors who told you that your headache's coming from intracranial hypertension aren't as knowledgeable about how the upper neck structures cause headache. Kimmy, would you use BMC for just SI joints, TMJ posteriors, or you need to be getting PICL to warrant doing a bone marrow aspiration? No, we have used it for those other things as well. I mean, that's a discussion with the patient and a clinical discussion, right? So we have a clinical discussion with the patient. Here's what I think would be best. And if there's no additional risk to doing BMC in that patient, then we can also have the discussion of, well, I would like to do BMC for these things. What do you think about that? And that's how we do this all the time. So there's a patient coming in this next week who would like to try if she sticks with posterior bone marrow for her posteriors, and that's fine. She's not going to add any additional risk, might add a little additional benefit. It's a lot more expensive. PRP would probably work just as well, but if the patient wants to do it, I think that's fine because it's not adding additional risk to that patient or significant additional risk. Becky, have you seen improvement of MCAS with posteriors only or just PICL? Mostly just in our PICL patients, I would say, based on just the gestalt of trying to get a sense of who has responded to what. Rishi, watched from jail stem cell documentary last night. Great job exposing this fakes in the industry. Encourage anyone watching this live, check it out. Highly recommended. Yeah, Rishi, that was kind of funny. I got contacted by, what was the guy's name? Doug Orchard. It was a number of years ago. And he wanted to do a documentary on stem cell stuff. And I started talking to him about all the crazy fraudulent stuff and quasi-fraudulent stuff that goes on. And he kind of grabbed onto it, and that's what he wanted to do. So I think he did a great job exposing all of that. And I think it's on Amazon, for purchase out there. I haven't seen it in years and years, but I'm in it, talking about a lot of that stuff. Greg, I saw you last month for PICL procedures along with some other injections. I am still experiencing pretty severe headaches. However, I have access to a doctor at Walter Reed who can perform prolotherapy and PRP under ultrasound guidance? Is there something I can ask and do to help severity, or it's just too soon since I had the PICL? Yeah, Greg, if you're talking about you're having headaches related to what you normally experience with headaches, it's way too early to see any kind of improvement from headaches from a PICL. Way back when, I would say fine if you want to get some additional PRP or Prolo from somebody. But interestingly, that hasn't gone well for whatever reason with most of our patients that have gotten interval PRP or prolotherapy between PICLs. More often than not, they just tend to get more flared up. Also, ultrasound is below standard of care for neck injections. You can do prolotherapy under ultrasound. But as far as hitting most of the structures that would cause headache, like 0-1 facet, 1-2, 2-3, ultrasound only would be below standard of care. Now, you can do things like occipital nerve hydrodissection under ultrasound quite well. So if that's the game plan, you may want to try that. But so far, we haven't had great experiences with people getting that stuff between PICLs for whatever reason. NARS, what are your thoughts about calcitonin gene-related peptides, self-injectables such as Aimovig, etc.? Yeah, again, I mean, that's a different class altogether of migraine-like medications that are probably not working at all on the vascular component of the migraine. So those are the kinds of medications that patients usually end up on who have cervicogenic headaches. It helps some, but it's not knocking the ball out of the park for most of our patients. And that's really what this is about, right? These people are kind of stuck on the neurology track, and they need to get moved over to the interventional pain track and see what's going on in their upper neck. Rishi, when hydrodissecting the GON, are you able to hydrodissect through muscles? Yeah. Yes. So in particular, when we're doing what we call a C2 car wash, kind of a crazy name, that's exactly what's done. So we are at that semispinalis capitis muscle and hydrodissecting out the muscle layer where the nerve goes through at that level. Rishi, is there a way to tell if occipital nerves are swollen or compressed using ultrasound machine to visualize the nerve or nerve conduction study? Definitely not a nerve conduction study. Sometimes you can see some swelling in the nerve, but the problem is the nerve really isn't well visualized in that area. You mostly end up seeing the artery that goes with the nerve, and the nerve is very, very small. So the answer is, unlike a carpal tunnel, where you could easily see the nerve and get a diameter on the nerve, you're not really going to be able to do that very easily with an occipital nerve. Rishi, can you inject the occipital muscle when performing occipital nerve hydro? Yeah, any of the suboccipital muscles could be injected as well. Bo, my daughter gets migraines. I notice bad posture and her head naturally rests leaning toward one side. Could misalignment cause these? Yeah, so anyone who's been diagnosed with migraines needs to have their neck looked at, right? Neck is probably the single most common cause of headaches out there, even more common cause than migraine. So it needs to be looked at as a possible cause. Rishi, what's the difference between 3rd-gen platelet lysate and 4th-gen platelet lysate? Biggest difference is just dialing in the platelet lysis and dialing in and getting more growth factors out of the platelet. Rishi, is there a way to customize and amp up nerve growth factor and vascular endothelial growth factor to its very maximum in the lab for hydrodissection? No, not really, Rishi. We know that platelets contain certainly enough of both of those to do some really good things with nerves. There's multiple studies on that now, not only with regard to animal models, but also actual clinical randomized controlled trials. So all platelets, whether it's PRP or platelet lysate, will have a relatively positive effect on injured nerves. I think I answered that one. AT, for patients that are dealing with an overload of postural muscles from CCI, how should that be handled? Should strengthening these muscles be completely avoided? Yeah, I think you've got to take care of the postural issue that is overloading the muscles first, and then you can look at strengthening in a proper way. But I think what you're talking about is an important point, and that is that if you were to strengthen into bad posture, then you're going to be strengthening the problems that led someone into that issue, and that could be a big issue. Said issue too many times there, I think. James, does it ever make sense to try posterior prolotherapy injections first to treat type 3A CCI if diagnosis of CCI isn't clear from DMX, which is the case for me? Sure. Yeah, I told lots of patients, listen, I mean, posterior prolotherapy, if you've got a competent provider who's using ultrasound and who's been doing it for a while, is a great way to treat type 3A. That's where C2 is moving forward on C3 inflection, and should definitely give it a try. If obviously you're in a situation where you do that a couple times and it's really not making a difference, then it's probably not going to, and it's time to go to the next level. I wouldn't get into a situation. I've seen some clinics out there that kind of keep patients hanging on, if you will, that say, it's going to take 8, 10, 12, 15 prolotherapy visits to try to get someone to respond. I've never had that experience. People respond very quickly to prolo within the first 1 or 2 procedures. And there's nothing to make me think that if they haven't responded in the first 1 or 2, they're going to respond at the 10th. I think that's more of a business plan than it is a clinical plan. So be very careful about that. Kimmy, about the SCM and the ears. When I flex my neck, my left SCM is huge, but right SCM barely does anything. How do I know if the muscles are too tight, normal, or if they're atrophied? Neither side is painful, but they're very clearly uneven, not working in the same capacity. Kimmy, that could be because of the upper cervical instability, but a really easy thing to do would be to try to find a myofascial release therapist in your area. Just go in and type myofascial release, go to that provider, have them take a look at your SCMs, and see if you're a candidate for that kind of treatment. That would be a good next step. Robert, is a relationship, or is there a CCI relationship when squatting to standing? Type of hypotension, eyesight dimming, depending. I think you're talking about more POTS-like issues. Let me know if I'm incorrect there, meaning postural changes that are leading to orthostatic hypotension. And that's super common in CCI population. Probably 1 in 4, 1 in 3 of our CCI patients have POTS as a feature. And usually we believe it's vagus nerve related. If you get rid of the vagus nerve irritation, it goes away as well. But let me know, Robert, if you're talking about something else there. Aaron, I've been diagnosed with CCI type 2. So be either 2A or 2B. So maybe let me know which of those. DMX shows elongated styloids, and ultrasound shows compressed jugular veins, mostly on the right side. Do elongated styloids usually are usually the cause of compression? No. So a couple of things to unpack here. Ultrasound is not a valid way to look at this problem. And that's because ultrasound is too operator dependent. So being able to see that area under ultrasound where the styloids are is very unreliable. And we don't recommend doing that. If you want to get an accurate read on something like that, you would get a CT venogram. That's going to be a much more reliable way to look at the problem. The issue is that lots and lots of people have elongated styloids. So to think that the elongated styloids are the cause of the problem Doesn't make any sense, right? We got lots of people. If we take 100 people off the street right now who are walking around out there, don't even know what we're talking about, and we bring them into a room and we go ahead and look at the length of their styloids, let's say on an x-ray, probably about 40% of them are going to have elongated styloids. They've got no problems. So how can we say that elongated styloids do anything in this? Now, what elongated styloids can do is if you've got instability and something pushing forward on that vein or other nerve structures, then it might increase the risk with instability of someone having symptoms, but it's the instability causing the problem, not the styloids. And if we go ahead and clip the styloids, we destabilize the anterior neck, and in my experience, usually making many of these patients much, much worse. And then we get back to the same issue of IJV compression, common in people without symptoms. So how do we know that the IJV compression is causing symptoms? We really don't. So kind of getting back to that whole discussion. So at the end of the day, I wouldn't trust the diagnosis under ultrasound of compression at the IJV because it's too operator dependent. Daniel, what can be done to improve IH? I have headache that increases maybe when the pulse goes up. I think that's what I'm hearing. So again, the first line of treatment, if there's craniocervical instability, is to treat the craniocervical instability. We may need to follow up with some additional DMX to make sure that that actually went away. Assuming it did, then you can always go to the second line treatments to try to decrease IIH. And that might be, maybe you're the rare patient with severe enough IJV stenosis at that level who requires something to be done to open that area up. That can certainly be there. It's just that's much more aggressive and invasive. So we start with less invasive things first. And if that doesn't solve the problem, then we can always go to the more invasive thing. Regrettably, I see a lot of patients doing it backwards. They try the more invasive thing first. I just saw a guy this week from England, right? He had some guy over there put a stent in his IJV because they were convinced he had intracranial hypertension. It made it worse. Then he had the same guy, maybe a different guy, put in another stent inside that stent because there was possibly some stenosis of the original stent. Now he's got two different stents in there. And I will tell you what was the most fascinating under ultrasound, looking at the flow through the stent, was it is so much different than the natural side. The natural side has a vein that's small, and as the blood flow comes through the vein, it opens and pulses naturally. This side is just one big old pipe in there. And there's even different flow patterns within the pipe, so to speak. And that pipe is now putting pressure on the sternocleidomastoid muscle, probably causing new issues. So, man, I felt bad for this guy because he's kind of down this crazy rabbit hole that he can't get out of because he can't even find anyone over there that'll even talk to him about what the next step is. No one wants to remove the two stents that are in there because now you're getting into super high risk procedures where you could kill this guy just by trying to take these stents out. Sharon, hi, Dr. Centeno. Do upper cervical muscles get atrophied after years of bracing from instability? Muscle atrophy from CCI be reversed? Yeah, the cause of this, we don't really know. I think as I've told the story before, one of our old physical therapists 20 years ago, James Elliott, ended up getting his PhD on this very topic. And now James is a full professor at Northwestern and does research on upper cervical muscle atrophy. The upper cervical muscle atrophy, no one's quite sure why it's caused. My guess would be it's probably caused by pain coming from the upper neck joints and injury to those joints, which then inhibits the muscles, which then causes atrophy, and then the whole thing just kind of spirals from there. More instability, more pain, more atrophy, etc. Can muscle atrophy from CCI be reversed? The answer is probably. No one's 100% sure yet, but the answer is probably. Sharon, have you seen patients getting more unstable from doing AO for many months? My adjustments are perfect, but after every adjustment, I feel more loose and heavy head. I tend to flare up more and more. Yeah, so then you may not be a good candidate. Listen, we have patients that aren't great candidates for upper cervical chiropractic. That's certainly a thing. Um, or they've got the wrong vectors. That's also a thing. But you may not be a candidate for that. It doesn't sound like it's a good fit for you. AT, thanks for amazing info, Doc. Wanted to share that I'm doing my ups and downs with CBP, beginning lower and thoracic adjustments and hypomobile areas has helped take tension off from there. Great. Sharon, I thought you were not a fan of prolotherapy and PRP combo. Curious to know why. I think, Sharon, what you're talking about is if you combine prolotherapy solution with PRP, meaning in the same syringe, you get platelet raisins. So I'm not a fan of platelet raisins. So I think that's what you're talking about, meaning that, for example, a dextrose prolotherapy solution works because you are causing local damage to the cells by that hypertonic solution. If you add platelets or PRP into a hypertonic solution in the same syringe, then the platelets dehydrate and the water gets sucked out into the hypertonic solution and you get platelet raisins, you get dysfunctional platelets. So I think what I've said in the past is for providers that are trying to combine PRP with dextrose prolotherapy in the same syringe, or trying to combine bone marrow concentrate with prolotherapy in the same syringe, not a good combo. So I think that's what you're mentioning. Rich, does the PICL procedure needle pierce the ligaments? If yes, does that damage them at all? Also, once the stem cells are injected, how do they stay in place? Yeah, so Rich, ligaments are fibrotic things, fiber-like things, lots of small fibers. So the average ligament, let's say like an alar, would have 1,000 different fibers in it, fiber collagen bundles. And the needle would kind of go between those bundles for the most part. Think of if you took 1,000 pieces of thread and you lined them all up and you had them attached to two things and you made them tight. Your 1,000 pieces of thread, if you were to, you can put your finger through it. So maybe it's this thick now, right? 1,000 pieces of thread. You can put your finger through it. You're not damaging any of the thread, or you're doing minimal damage to all of the threads, but you can get into it pretty easily with minimal damage. And if you're going to try to inject something into your 1,000 needles of thread, it's going to stay there. If you're going to inject small little BBs into it, for example, the BBs will generally stay there. Some of them will come out, but most of them will stay in the threads. Same concept here. Rishi, look forward to seeing you next week for treatment. Sounds good. AT, so ultimately correcting posture and getting closer to ideal sagittal alignment should help with postural muscle fatigue, overload from CCI, and strengthening areas can be managed correct. Yeah, I would say that's the correct sequence there. Kimmy, I've done the email surveys on pain levels pre-PICL and 5 weeks out, but they only talk about pain and other symptoms. Do you have a similar one for neurologic symptoms, or should we answer strictly about pain levels? Just answer strictly about pain levels on those. The neurologic symptoms will be picked up by the functional questionnaires. Ryan, I hear thoracic outlet is common in CCI patients. The one I think I have is the one deep in the pec minor area under the armpit. Going to give me time to see if it improves the time and help me with visibility. If it doesn't, what would be the next step? Yeah, so those areas can be individually hydrodissected. That pec minor area can, the scalene type thoracic outlet can. So that would probably be the next step if that didn't just get better on its own. It's been advanced by Sherry Scott. Does POTS always have a CCI component, or can it sometimes be a heart issue only? Oh, no, yeah. I mean, POTS can be caused by lots of things. And that's one of the things I always tell CCI patients in general is if you've got a cardiac issue, you've got to see a cardiologist, right? You've got to get the stamp of approval from a cardiologist that says, I don't know what's causing this. You don't have A, you don't have B, you don't have C, you don't have D. I don't think you got a heart problem. Look elsewhere for the cause of this problem. So that's pretty critical in our patients, is to make sure that that expert has seen the patient so that we can get some idea, certainly on the cardiac stuff, that that's not coming from something we would miss as musculoskeletal providers. Okay, well, I could be a record here. For a couple of these, I've not gotten to all the questions, but I think I got to all the questions here today. So I think maybe we'll start winding this down here. So this coming week, I'll be doing another one of these, and that'll be my last one before going out. I'll be out for 6 weeks. I will be doing automated Facebook Live like things. You guys will be able to comment to your heart's desire. I won't be live, but they'll be going out automated once a week for 5 weeks there until we get back. I've already prepared those. I think those are good to go. There'll be a little morning announcement that'll come out, and then you would want to do the video same time as this one. So hopefully those will continue the conversation, and then when I get back, I'll be doing all of these. So one more of these next week with another topic, and then I'll be doing 5 topics while I'm gone. There's some pretty good ones coming out while I'm gone. One of the ones I think you'll really be interested in is translational BAI. I kind of did a deep dive on the literature. Translational BAI is a very common one with many of the surgeons. They use that to look at whether or not someone's got CCI. And I kind of did a deep dive on what that number should be, what the maximum should be on that. And so I think you guys will find that interesting, those of you that have had your translational BAI numbers discussed. And then another one coming out will be on rotational CT, how we see a lot of patients getting qualified with CCI using rotational CT, and what those numbers should be versus how people are getting qualified based on what's published. So lots of other things. I think I've got 2 on rehab, how you should rehab from CCI, all the little things you should consider getting treated with your CCI to try to maximize the chance of recovery from CCI. So lots of different things coming out there. And I will see you guys next week. You all have a fantastic weekend. Thank you.